Good morning, good afternoon, good evening. It's a great pleasure and honor to address your conference, and I wish I could be with you in person. I'm Dr. Catherine Pettis, Senior Advocacy and Partnerships Director for the International Association for Hospice and Palliative Care. I'm a political theorist, not a clinician, and I'll talk to you about how, as a professional association, you can leverage the international policy framework structured through the United Nations to expand and improve the care of your patients. We'll begin today by looking at what the International Association for Palliative Care is, what we do, and why advocacy is important. Then we'll define the international normative framework and take a look at how that framework commits the Indonesian government and all member states in the world to provide palliative care and essential palliative care medicines as a public good. And lastly, we'll review how national advocacy by your professional association can help your government implement this framework. I'll be talking about that as we go along. So we are a mission-driven organization. Our vision is a world free from health-related suffering, and our mission is to serve as a global platform to inspire, inform, and empower individuals, organizations, governments, and organizations such as yours to increase access to and optimize the practice of palliative care. We do this through our 4 pillars of work, which are advocacy, education, research, and knowledge dissemination. And if you take a look at our website, you'll see lots and lots about all those 4 things. So the IAHPC, the organization of which you're a member, has almost 1,400 members in 156 countries, and that number changes every day as people join, as their membership lapses, or they renew their memberships. This map is on our website under the membership tab, and you can click on the dot and see who's a member in Indonesia. There are many membership benefits, including online clinical courses, as well as an advocacy course, and scholarships for conferences. Students can join for free for the term of their studentship, and we're legally accredited, as it shows on the right, with the UN organizations such as the World Health Organization and the Economic and Social Council, meaning that we can advocate for palliative care at their meetings and provide technical support to Secretariat staff. So our advocacy partners in the UN system are the World Health Organization, and we go to the World Health Assembly every year, the Human Rights Council, the Commission on Narcotic Drugs, the International Narcotics Control Board, or INCB, which regulates the controlled medicines that come into your country for consumption every year, and the UN General Assembly. So we advocate at all those organizations' meetings to make sure that member states include palliative care in their political declarations and resolutions, and then organizations such as yours can leverage those documents to advocate for palliative care in your country. So now I'm going to talk about what's called the normative framework. So first of all, why should you, as palliative care doctors and nurses, care about the international normative framework since it's not even taught in medical school? The short answer is that you should care about it because it'll help you care for your patients. A normative framework is the structure of norms, laws, and standards that all member states, including Indonesia, have agreed on in multilateral meetings at the United Nations, in those organizations we just talked about. So they've all agreed that palliative care should be a normal, there's that word again, part of the health system. Palliative care should be normative. And so they've set up laws and standards to govern that in the international system. So all governments have agreed and committed to language that states, and this is from the World Health Assembly resolution, that palliative care should be a routine function of all healthcare systems. They commit themselves through the different documents. We're just going to look at a few of them. And it's up to you as a legally constituted professional organization to advocate with your governments to operationalize those multilateral commitments that your government has agreed to. It's as if, just to give you an example from the medical community, it's as if they've given their prior consent to your clinical services in the country and said that all people, all Indonesian citizens, should have access to those services through publicly funded programs. And your association can offer to advise them and work with other key partners, and I'll mention a couple of those, to put into practice the policies and put funding in place to make that international normative framework, which we're going to look at, real in your country to benefit your patients and families. So it goes from the global level to the bedside. And that is the work of advocacy. Why do we do that? The international normative framework was designed to protect what are called global public goods, such as peace, health, development, and security. That's what the UN was devised for. And the World Health Organization has named palliative care as a global public good to mitigate the public health harms of chronic disease in the growing world population of older people, just for instance, because of course children also need palliative care. But as the world population ages, the 86% of the global population that currently has no access to palliative care will only increase. And this rise in population is accompanied by, of course, life expectancy rise and the rise of non-communicable diseases or chronic diseases such as dementia, cancer, heart disease, which is a source of a great deal of serious health-related suffering, which you as doctors are called upon to deal with, and which palliative care can alleviate the symptoms of. The need to integrate palliative care into health workforces and workforce education is urgent, or preventable suffering will increase. On this chart, the Asian region is the dotted blue line, this line here, showing the number of people over 60 by the end of the century. And as doctors, you'll need to ask yourself, how will palliative care be integrated into your health system so that you can relieve the suffering of those patients? Will there be enough doctors and nurses to care for them? Will there be enough medicines? Will people know how to use those medicines? Again, that's the work of advocacy, and the global normative framework already supports you to do those things in Indonesia. And one of the resources we have now is this Atlas of Palliative Care for the Asia Pacific, which some of you may have seen at the APHN conference earlier this year. and it was published in 2025. And this new atlas for palliative care in the Asia-Pacific region shows that palliative care provision is isolated in Indonesia. Your government has agreed that palliative care should be part of primary health care under universal health coverage, and your health law, your national health law, references its integration into all healthcare settings, particularly into primary care. A 2022 policy brief from the Indonesia Ministry of Health reports that palliative care coverage for terminally ill cancer patients is below 1%. Although most hospitals, including private ones, are offering palliative care, it remains inconsistently available, as I'm sure you know better than I do, nationwide. Palliative care services are typically limited to inpatient consultations and outpatient clinics, with few hospitals providing dedicated palliative care beds or wards, which restricts comprehensive care. Home care services are scarce, often relying on out-of-pocket payments, so poor people can't afford them, or, if they're lucky, support from civil society organizations such as the Indonesia Cancer Foundation. Your country's law on palliative care both aligns with and strengthens the global normative framework, which is based on universal rights, since Indonesia, of course, is part of the international community. The Committee on Economic, Social, and Cultural Rights in 2000, that's part of the Human Rights Council, ruled that palliative care is now part of the right to health, and that's binding international law. And that committee said that palliative care should be provided universally, even to prisoners or detainees, minorities, asylum seekers, and illegal immigrants, along with preventive and curative care. So this is what's called General Comment 14, which the Human Rights Council approved, which now recognizes palliative care as part of the right to health. And then, of course, there's the World Health Assembly resolution, which I'm sure most of you know about, 6719, which says that palliative care is part of the right to health. It's an ethical responsibility of health systems and an ethical duty of all healthcare professionals. Just last month, the Human Rights Council approved a resolution that recognizes access to palliative care as part of the right of older persons. And so that resolution in 2021, there was another one this year too, but this one was 2021, which explicitly encourages all states to provide long-term support and palliative care services to older persons and to promote the development of comprehensive care systems. So Indonesia approved this resolution at the Human Rights Council, and you can leverage it to improve the amount of services and training for healthcare personnel. The other important part of the Human Rights Council working group that Indonesia can help to strengthen the global framework for palliative care is to advocate and make sure that your delegates in Geneva advocate for inclusion of palliative care in the Treaty on the Rights of Older Persons, which is to be drafted in Geneva next year. This treaty will only include palliative care standards as part of the right to health of older people if national associations such as yours advocate with their governments that are members of the working group that was set up by the Human Rights Council that will draft the treaty. IAHPC's advocacy laid the groundwork for this and made sure that palliative care is included in all the background documents. So your government can just draw on those documents and we can help you. We can supply all that paperwork. Once the treaty is drafted and approved, there needs to be national and state level legal frameworks within Indonesia. So it doesn't work just to implement what's happened at the global level. It's not self-implementing. Each country has to implement it itself. So that's the second part of the work of your association. The first is to advocate with your government that the delegates in Geneva make sure palliative care is included. And then once the convention is approved, that it's implemented in your country. And again, IAHPC can assist with that. The Astana Declaration on Primary Healthcare was a key part of the international normative framework approved by all member states. It updated what was called the 1978 Alma Ata Declaration. And that earlier international document, look at the date, 1978, did not mention palliative care because it hadn't been born yet. Palliative care really wasn't being practiced in the mid-20th century. It really came into its own in this century. So now the Astana Declaration on Primary Health Care includes palliative care as part of the continuum of primary health care services. So Indonesia should include it in all primary health care services in your country. And now we get to essential palliative care medicines, such as morphine, for instance, that's just one, and the drug control conventions. Again, these conventions, like Alma Ata, were enacted before the development of palliative medicine, before we had evidence about the benefits of essential palliative care medicines for pain relief, and before the development of a knowledge base about the treatment of substance abuse disorder. Yet many governments, including Indonesia, have drug control laws that are outdated and still overemphasize control of an illicit drug use, which is important. I'm not saying it's not important, but they overemphasize control at the expense of safe availability for medical purposes, because they don't realize, and you can help them realize this, that it's possible to achieve both those goals through balanced policies. The IAHPC has been working on this for about 15 years, and we finally had a breakthrough in 2016, with the UN General Assembly special session on the world drug problem. So this is called the UNGAS, UN General Assembly Special Session on the world drug problem, and this was the outcome document. And that breakthrough that we had took place in New York at the UNGAS following 2 years of debate and negotiations in Vienna, where I was privileged to participate in drafting the text. Indonesia was one of the countries that agreed to the text in the introductory paragraph of Chapter 2, which says, "We reiterate our strong commitment to improving access to controlled substances for medical and scientific purposes by appropriately addressing existing barriers in this regard, including those related to legislation, regulatory systems, health systems, and affordability, as well as the training of health professionals, education, awareness raising, estimates, assessment, and reporting, benchmarks for consumption of substances under control." So you can review that document. It's listed in the resources. So this introductory paragraph of Chapter 2 was followed by 7 operational paragraphs of recommendations for member states to follow in order to address all those barriers. And I understand a colleague from the UN Office of Drugs and Crime was recently in Jakarta this year to follow up on a project endorsed by the government of Indonesia during the 2023 program governance meeting with the Ministry of Foreign Affairs and the Ministry of Development and Planning. So those are your government organizations that were part of these meetings. And the implementation focuses on three main areas: addressing legislative and policy gaps, building healthcare professional capacity, so training, and improving supply chain management, all very important. Key stakeholders at these meetings this year included the Ministry of Health, the Food and Drug Administration, the National Narcotics Board of Indonesia, and the Indonesia Cancer Foundation, as well as the Rachel House and the Faculty of Pharmacy at Gajah Mada University. So there's plenty of other people now that you can work with to improve availability of controlled medicines, which are essential for routine palliative care. And the reason you need to do this, and the issue that those meetings were dealing with, is the fact that availability of controlled medicines in Indonesia is very low. Reported consumption, and again, this is from that atlas I talked about earlier, reported consumption of controlled medicines in Indonesia is 27 standardized daily doses. That's how the UN measures it, SDDs, or standardized daily doses. And they use that to compare with other countries. And in Indonesia, it's very low compared with the rest of the regional. And the regional maximum is 7,000. So overall availability of medicines for pain and palliative care at the primary level is considered poor to fair in urban areas and poor in rural areas. Morphine availability, as you know much better than me, is generally poor in both rural and urban areas. Public health centers offer occasional home visits and emotional support, but limited access to strong opioids hampers effective pain management. So that means that people are in preventable pain, which you can improve if you can improve availability of opioids and training of your healthcare workforce. Currently, Darmes Cancer Hospital is the only facility with a fully operational palliative care unit, and advocacy efforts are ongoing to integrate palliative care into primary care settings. The Ministry of Health is actively working on developing a technical guideline for this, but effective implementation of your national law requires further recommendations and stakeholder engagement. Stakeholder engagement means associations such as yours. And I strongly recommend that you review the atlas to develop an advocacy plan to implement your existing laws, because you already have a legal framework. And the IAHPC assists its members, and you are a member, to do that on request. So, as Indonesia's a predominantly Islamic country, it's important to understand that the Islamic Code of Medical Ethics permits the use of opioids to treat severe pain, explicitly permits it, as long as it's not intended to end the patient's life. Once pain is relieved, patients can pray and meditate on scripture and interact more happily with their family. In fact, the International Islamic Code of Medical and Health Ethics says cancer patients must be given pain medicine, remember God, and be patient about residual, inevitable pain that cannot be relieved medically. A heavy dose is permitted if necessary, provided the intention is not to kill the patient. And the World Health Organization just published a guideline in September on balanced national controlled medicines policies in September, marking the first comprehensive global framework designed to ensure access to controlled medicines while minimizing risks to public health that may arise due to misuse and diversion. Remember, I said earlier, governments can do both. They can promote access while reducing harm. This is an essential tool for your association's advocacy to improve availability. The WHO guideline provides civil society organizations such as yours and governments with evidence-based recommendations covering 7 key domains: policy development, pricing and financing, because in many cases medicines are too expensive, medicine selection, procurement and supply chain, regulations, prescribing and dispensing, and education for both health professionals and the public. And the IAHPC will be holding a webinar on November 13th to address this issue. So make sure you're signed up to our communications on our website. So go to our website and you'll get our special announcements telling you how to register for our webinars and courses. And last but not least, of course, you all remember COVID and how much you needed to have palliative care in place, and palliative care medicines, of course. The new pandemic treaty, which is binding international law, prioritizes a primary health care approach and instructs each party to take appropriate measures to develop, strengthen, and maintain a resilient health system, particularly primary health care, for pandemic preparedness and response. And the next clause says that you should have equitable access to scalable clinical care and quality, routine, essential healthcare services with particular attention to persons in vulnerable situations. And of course, this means seriously ill people, children, poor people, people on the streets, in prisons, in nursing homes, and other sites of structural vulnerability. This treaty authorizes you to advocate for those populations, and you also need to advocate for adequate national stockpiles of essential palliative care medicines to prepare for a future pandemic. So you have to have the emergency stockpiles in case international trade is cut off like it was in medicines during the pandemic. This treaty won't operationalize itself. Just like the Older Persons Convention I was talking about. It's been approved by WHO, but it has to be operationalized at the national level, and national advocacy is essential to leverage these clauses. And then it can happen in Indonesia because your government approved it. So thank you, and I really appreciate your attention. As I said, you are a member of IAHPC, and I'm here to help you and help you implement all the things I talked about if you are willing. Here are a few of the references I referred to, and there's many more on our website. Have a wonderful conference, and I look forward to meeting with you again one day.